Okay, let's dive right into this explainer and demystify the incredibly high-stakes world of pediatric dosage calculations. Look, if you've ever stared down a tiny infant's medication order and felt your heart rate spike just a bit over the math, you are definitely not alone. We're going to break down the hard and fast rules and safety standards of pediatric medicine together.
To make sure we're getting this absolutely right, we're extracting the core formulas straight from this rigorous maternal child nursing test bank. It's totally packed with real-world scenarios, which is perfect because it lets us walk step by step through exactly how these calculations play out in practice.
I want you to think about this question for a second. How do you calculate a safe dose for a 48-pound child? This isn't just some abstract algebra homework. That 48-pound child represents a real, breathing human life, which firmly anchors every single number and decimal point we calculate in real-world stakes. Consider this your syllabus for the explainer today. We're going to cover the crucial first step, then calculating the daily dose, determining safe dosage ranges, reconstitution and administration, and finally mastering maintenance fluids. Starting off with Section 1, the crucial first step. In pediatrics, weight is everything. In adult medicine, we often use standard flat doses, but with kids, almost everything is meticulously tailored to their exact size. So this brings us to your golden number, 2.2. In the United States, we weigh babies in pounds and ounces, but medicine strictly speaks the metric system. To convert pounds to kilograms, you simply must divide the pounds by 2.2. It sounds incredibly basic, but if you don't get the patient's weight right here, nothing else matters. You cannot skip or estimate this. Let's look at what happens when a baby comes in weighing 17 pounds and 9 ounces. You don't just eyeball it. You follow 3 precise steps. First, divide those 9 ounces by 16 to get a decimal, which is 0.5625. Next, you add that decimal right onto the 17 pounds. Finally, divide that total of 17.5625 by 2.2. That gives us exactly 7.98 kilograms, which we can safely round to 8 kilograms. It's all about precision from step 1. All right, Section 2. Calculating the daily dose, which is really the bread and butter of pediatric medicine. Now that we've got our weight in kilos, let's tackle the formula used in nearly every pediatric scenario. Memorize this mantra right here. Convert, calculate, divide. This exact sequence is the engine that drives your dosage math. First, convert the weight. Second, calculate the total daily dose by multiplying the weight by the ordered milligrams per kilogram. Third, divide that total by the number of doses per day. And lastly, figure out the actual volume in milliliters based on the medication's concentration. Let's apply our mantra to that 48-pound child we mentioned earlier. First up, 48 divided by 2.2 gives us 21.8 kilograms. Next, we multiply that by the ordered dose, 40 milligrams per kilogram, meaning they need 872.7 milligrams for the entire day. Since it's ordered every 8 hours, we divide that daily total by 3 doses. That gets us 290.9 milligrams per individual dose. Finally, we look at our concentration, which is 375 milligrams per 5 milliliters. Divide our dose by that concentration, and it turns out we need to drop exactly 3.9 milliliters. Now, doing this math brilliantly illustrates why you absolutely must use leading zeros like 0.6, but never, ever use trailing zeros like 6.0. Why? Because if someone reading your chart misses that decimal point, 6.0 suddenly becomes 60 milliliters. That's a fatal 10-fold error, literally just from how a number was written. Moving on to Section 3, determining safe dosage ranges, which is all about establishing the limits of care. Because it's not just about doing the math to get a number. It is about ensuring that number doesn't harm the child. Let's run through a real preoperative scenario with midazolam. Say your reference states the safe dosage range is 0.07 to 0.08 milligrams per kilogram. When you're checking this, always calculate the maximum limit using the highest number in that safe range. You need to know exactly where the ceiling is to completely prevent an overdose. So for a 132-pound preoperative patient, we'd first convert their weight to 60 kilograms. Then we take that absolute upper limit of 0.08 and multiply it by 60. That math gives us a strict, hard stop maximum safe dose of 4.8 milligrams of midazolam. If the doctor orders more than 4.8, you don't just blindly give it. You stop and you question it because you are that final line of defense. Okay, Section 4, Reconstitution and Administration, Mixing Meds and Double-Checking Math. Moving beyond your standard oral suspensions, let's explore reconstitution, where we're actually turning powdered medications into precise injectables ourselves.
Visually anchor this number in your memory: 1,000. In pharmacology, you're constantly bouncing between grams, milligrams, and micrograms. You just multiply by 1,000 to convert grams to milligrams or milligrams to micrograms. So 0.25 grams, multiply by 1,000, and boom, you know you're dealing with 250 milligrams.
After you do your reconstitution math, dividing the ordered dose by the concentration and multiplying by volume, remember that the math is only half the job. You have to label multi-dose files with the date, time, and your initials. And crucially, high-alert medications like heparin have a notoriously narrow margin of safety. They require an independent double check, meaning a second nurse has to completely review your calculation before a single drop is given.
Which brings us to Section 5, Mastering Maintenance Fluids, often considered the final boss of pediatric calculations. Getting a child's continuous IV fluid needs right is absolutely critical, because a misstep here can cause severe dehydration or dangerous fluid overload.
This perfectly illustrates the famous 10-20-70 rule. It shows exactly how daily fluid requirements scale up with the child's growing weight brackets. For their first 10 kilos, it's 100 milliliters per kilo. For the next 10 kilos, you add 50 milliliters per kilo. And for anything over 20 kilos, you add 20 milliliters per kilo.
Let's try it out on a 14-pound infant. Converting that weight gives us 6.4 kilograms. Because they fall right into that very first bracket, we just multiply their 6.4 kilos by 100 to get a 24-hour total of 640 milliliters. To figure out the IV pump setting, we divide that by 24 hours, giving us a continuous infusion rate of 26.7 milliliters per hour.
Before we wrap up, we hit Section 6, the stakes of precision, responding to errors and near misses. Because despite all these formulas and strict rules, we have to talk about what happens when vital calculations actually go wrong in a fast-paced environment.
Look, mistakes are a terrifying reality. But if an error does occur, your immediate, undeniable first priority is always the patient's physical safety. You assess them for adverse effects right away. Only after you know they're stable do you fulfill your legal responsibility to notify the provider and file an incident report. We legally and ethically have to report these so we can improve systemic safety for everyone.
So, the crucial point I really want to leave you with is this. Precision in pediatric dosing isn't just about passing a math test. It's the ultimate act of patient advocacy. Knowing the severe, life-altering risks of a single misplaced decimal point or a sloppy abbreviation, how will you approach your next calculation to protect the life right in front of you? Keep your math sharp, trust your formulas, and always take that extra second to double-check your work.